Okay, my name is Joanna Taylor, and I am director of Noi Group Europe. And I am joined this afternoon by Noi Group teacher and my very good friend, Dr. Ben Davies. Hi, Ben.
Hello. Hello, everybody.
Welcome back, Ben. For those of you who have missed our previous sessions, Ben is an advanced practice physiotherapist specializing in persistent pain and rheumatology. He brings over 15 years of experience teaching explained pain with a gift for making complex neuroscience accessible and immediately applicable. So it's great to have you back, Ben. Thank you. Could you just remind everybody a little bit about what you are doing currently in your work?
I work I work at a hospital called the Royal National Hospital for Rheumatic Diseases, the RNHRD, that's based in Bath. It's one of the oldest hospitals in the UK that's sort of in existence. But we run a residential program for axial spondyloarthritis. So it's a 2-week program, and people from around the UK come and stay with us. I think it's pretty much the only one, I'm going to say globally, such an intensive 2-week rehab program as a multidisciplinary team for that condition.
Thank you. Amazing. These sessions that we are doing today are all about giving you a taste of explained pain and how to practically use it in the clinic. Now, some of you in the audience will have already done an explained pain course, and for those of you who have, these sessions can both reinforce and extend what you have already learnt. But if you're new to explained pain, this will give you a taste of what is covered in the core course. But as I said before, Ben has got a 2-day online course coming up on the 4th and 5th of December 2025. And for anybody who is interested in attending that, we'll give you some more details about that at the end. So just hang around at the end and you will hear about the format of that. So a couple of things to mention before we start. Ben and I are going to be talking for about 25 minutes. If you have any questions, please pop them in the Q&A or in the chat, and we'll get to as many of those as we can. I would urge you to try and get your questions in earlier rather than later, because we do tend to run out of time. And if you want to watch the recording of this session, you can access it in the Clinical Discussion YouTube channel. Okay, so today we're going to be talking about pain and why your body also gives you fatigue, tension, and sleep problems. So, Ben, just briefly, could you tell us what we're going to cover today?
Um, yeah, I'm going to do my best not to mention pain in any of the answers. I want to try and make us think about all those other things. I mean, pain is that reason why people come to us, come to our clinics, seek out professional help. But I'd like us to almost park that for a minute and think, just like you
Mm.
said, Joe, about other presentations of threat. How does our immune system respond? What does our mood happen? What happens to our mood? What happens to our immune system? How those things are all linked together.
Mm. Fantastic, thank you. So let's start with this concept of that pain is only one protective output, and that it is one of the target concepts in explain pain. Can you explain what we mean by this?
So target concepts, there's 10, and they might be the thing, like one of them might be the thing you want to get across to a person you're working with. And one of them, and we're going to link back to this, is that pain depends on a balance between danger and safety. So how much danger
Mm.
is someone in? What safety factors are there? In protectometer terms, these are DIMS and SIMS. But if danger exceeds safety, then pain may produce. So let's now park pain. If you're under threat, if things in life are not going well, what happens to your sleep quality? It's highly unlikely you're going to have a really good restorative night's sleep when lots of different things in life are perhaps a little bit perturbed. What happens to your mood state if you're sort of under threat? Do you notice that you have a pulling away from society mood state? Do you cancel social engagements? Do you pull away from work? Do you take time off? Do you sort of hide in the house, hide under the duvet? That's almost a physical presentation of something we might call depression. You hide in a cave. Or, and is your mood state shifted to be sort of super vigilant for everything around you in the world, super vigilant for how people are with you, super vigilant for slights that somebody might say that you take the wrong way, super vigilant for your body, really checking out every little bodily sensation? Are you more likely to get coughs and colds? Is that the time the cold sore breaks out again? or you might get some presentation of shingles or a urinary tract infection. Is your
Mm,
immune system sort of just slightly squonky? Is it just slightly out of kilter and out of balance? All of these presentations, mood, what we could think of as stress, muscle tension, are you just, holding yourself in a way that's not your normal? So pain could come with that as well, but that broad palette of how a person is when you're threatened
mm,
is is really the message to get across to people who all those things that we've just described are probably really familiar to people in the people who come to your clinical services.
mm. Fantastic. That's really interesting. So how does understanding this change our clinical approach?
So I think it's being able to lay the groundwork, and in many ways, I will say this on EP courses. Explain pain is around explaining pain. Is some explanation, is some education a treatment in and of itself?
Yeah.
Absolutely, it can be helping that person to understand is a treatment. But I think also, and I feel more fundamentally, it's a foundation on which your professional skills are built. So I'm a physiotherapist. There's many physiotherapists, chiropractors, kind of manual therapists on this call. If someone comes to you with pain, that's the reason they've sought your services.
Mm.
Sorry, my screen's just gone blank. 1 second.
Well, we can still see you. You're just a little bit.
Oh, sorry, I'm
Oh,
back. I think we've got a slightly slow bandwidth at the moment, so I'm sorry if I just freeze slightly. I'm back and
we
you're back.
we can see your name, but not your face.
1 second. Oh, there we go. Let's try this.
You're just a bit blurry. Don't worry. Keep talking. It's fine. I'm sure it'll
Um,
catch up.
when people come with pain to physios, they're very often expecting exercise or perhaps manual therapy or some sort of
Mm,
intervention like that. Being able to recognize there's more to this presentation, patient presentation, and crikey, and you're thinking this person probably needs some relaxation, for example.
mm. Oh, have we
Sorry,
lost you? That's okay.
Joe, I'm still here. I will just keep trying
Yeah,
to get
just
my camera back.
keep talking. And
It, it allows, well, it facilitates that person recognizing that the role for relaxation, the role for CBT, the role for sleep hygiene, sleep advice, the role
mm,
for things that will buffer your immune system could all have a relevance in improving their pain problem. We're not just treating the pain, we are treating the whole person and their whole presentation.
mm. Okay, so again, that's really interesting. Um, you so what should as a clinician, what sort of things should you be looking for differently, rather as opposed to just pain? And when do these and are you looking for correlation between the different presentations?
I think what you're looking for as a clinician is, and clinicians are by nature almost always empathic people. You're
Mm,
looking to recognize that someone is just a bit on edge. I think that's almost the broadest way to describe this. That
yeah.
people are sort of on edge. There's that sort of almost like a brittleness or an edginess, a sort of
Mm,
angstiness to people. It's not just about the pain. And what clinicians need to be able to do is, with respect and with humility, ask broad questions. How is can you tell me about your sleep? Can you tell me about how worried you may be feeling at the moment? Because worry is a very good shorthand for anxiety. How sad, how low are you feeling at the moment? It's a bit of a sadness might be a shorthand for depression.
mm. So what do we do with this information when we get somebody in front of us who we see as being on edge? They are displaying a lot of these different symptoms. What do we do with that information?
First of all, we've got to be mindful of, is our clinical profession acceptable for sort of dealing with what you think is the cause here?
Mm,
As mostly allied health professionals probably on this call, there may be some psychologists. We need to be mindful of not so much overstepping professional boundaries, but are we the right person for this person to be seeing primarily, or can we
Mm,
work with a team to support this person appropriately? So having links to your talking therapy colleagues, to psychology colleagues. We also need to be mindful of, I suppose, promising huge successes with a single unitary professional approach. As a physiotherapist, there'll be physios and OTs and physios and osteopaths and chiropractors who use psychology. OT colleagues on this call will use psychology much more. There'll be
mm.
there'll be psychologists perhaps on this call who will use exercise a little bit. But if you're a single profession, you might be struggling to provide the whole breadth of what this person needs to really improve their quality of life.
Thank you. So we have a question here from Mark Cole. It's probably a good time to ask it right now. So I'll read that to you. It
Mm.
is Ben. You mentioned the common expectation of manual therapy whenever a patient asks to see a PT and a chiropractor. Would you agree that using manual therapy techniques immediately helps the patient to conclude that he or she is dependent on therapist generated treatment strategies for his or her pain problems?
Um, no, I'll hold my hand up and say I'm a rubbish manual therapist. It's not something that I've ever used hugely, despite really sort of doing my best to learn the techniques. I think there's absolutely nothing wrong with using manual therapy, and manual therapy for a way of gaining put someone's trust, for highlighting that an element of their pain problem is changeable. It may be
Mm,
short-term change, or that contract between what a clinician does and what we ask then the patient to do as homework. I think there's
mm,
nothing wrong with manual therapy. I might challenge use of manual therapy long term. I might challenge the use of sort of top up sessions of manual therapy. I'd like people to be empowered to um, to self improve with
mm,
clinical guidance, but manual therapy can have a role in that.
Thank you. Thanks for that question, Mark. That was that was great. Thank you. Great question. And Ben, you mentioned when systems can't switch off. Can you explain the connection between chronic stress and these multiple outputs?
The biggest way I can, I'm really going to apologize for my camera just not, I'm trying to allow it and it just does not want to allow.
It's
I was
okay.
almost wondering, Joe, whether to leave the meeting and come back, but I'm concerned that might, I don't know, something, it might be even worse if I try that.
I
So,
think a lot of people listen to this on audio, Ben, anyway, so I
all right.
really wouldn't worry about it. We'll just keep going.
All right. So think about the best way to think about the physiological links between stress and these issues is what's called the HPA axis, the hypothalamic pituitary axis. The HPA axis is this link between brain and the adrenal glands that release cortisol into the system. There are two stress hormones. One is adrenaline, and that's or
Mm,
noradrenaline in North American parlance. Adrenaline is quick, short-acting, fight-flight response. It ramps up, 20 minutes, it's gone away again. Cortisol is a hormone that's released by this gland, and it ramps up over a few days, and it ramps away over a few days.
mm,
Now, if you've watched a horror film, if you've had a near miss on the motorway, on the freeway, then those processes happen. You have that fight flight and you have that rest and digest that follows. But if you are someone for whom life continues to have this drip feed of stresses, and pain, of course, can become a stress, and fatigue, of course, can become a stress in its own right, then cortisol, long-term drip feed cortisol, has impacts really across all the systems. It will increase the likelihood for osteoporosis. It will suppress your immune system. It increases weight gain. It has a correlation with depression and altered cognitive function. If you're not sleeping well, you're going to be more moody. If you're more moody, your intimate life and libido is going to be affected. If you've got all those things going on, the likelihood of you enjoying life is going to be reduced. You're less likely to be at work, exercising, socially
mm,
active. So it's this long term, and it's this long term background drip feed of cortisol in our system there's probably the most clear link between stress and then this wide presentation across skeletal systems, muscular systems, neural systems, thinking mood systems. The rest system, the rest and digest systems impaired, more likely to have IBS type presentations. So that link between cortisol is a really important story to tell, or nugget to have in your pocket to tell people about and have conversations about that topic, really importantly.
Thank you. Really interesting. I've got a question here from Jennifer, and it is: once the patient cognitively understands that their nervous system is responding to threat and outputting pain, but is still responding biologically to the threat of the pain, aka our natural response to want to make it go away, how would you suggest we then treat?
I think the aim for pain minimization is absolutely sensible, and whether that's through drugs or manual therapy, as discussed. But I think it allows people to, I suppose the other target concept is bioplasticity. Your bodies are plastic. This response that you have learned over perhaps months or even years or even decades, can that response be relearned, unlearned, learning back a more calming way? And so helping people to understand that activity, meditation, relaxation, mindfulness, breathing practice, how they deal with stresses. Everybody's life has got stresses in them, and some stresses are changeable and some stresses aren't. But how you respond to those things, how you might communicate with significant others, how you might have time for yourself, for some laughter, closeness with a partner, social time, even if those things are not at the level that you'd like them to be, initiating small steps and graded exposure and graded practice of those physical, emotional, cognitive, relaxing strategies, you can help that system relearn or learn back the original ways that it used to cope. We've also got to be prognostic and a bit cautious about how much we're promising that these things will cure that person of pain. I'm always, I'm sort of moderate. I mean, you want to be a bit, let's try these things and see how you find them.
Thank you. Fascinating. I'm coming back here now to the cortisol level, and Miriam has asked a question, and it is: does it make sense to measure the cortisol level?
I think, cortisol can be tested. Absolutely, medics would, endocrinology specialists, rheumatology specialists, perhaps they would measure endocrinology. They would measure cortisol levels for things like the words go off my head. If you're naturally or you're losing the cortisol function, it's not something I've ever done, and I wouldn't know what the criteria are for getting that testing completed, and I don't know the kind of clinical implications of that, I'm afraid.
Okay, thank you. There's a question here from Judy. She said, when will somebody find a real cure for CRPS? I think Ben kind of has answered that, but maybe just have a go at that one, Ben.
Oh, complex regional pain syndrome is one of those presentations where that threat cycle, the negative feedback of all of these things, has really got very difficult to control. And I think it highlights the role within CRPS management for sensible and appropriate medication, for an intelligent clinician, an informed clinician, to have these conversations about how mood, body perception, physicality all interplay for that condition particularly. And I think, again, there's no one profession that has the answers to CRPS, but using things like graded motor imagery, using mirror therapy, using active relaxation, using multi-sensory information. I think all of that is aiming in some ways to calm the system down. How much that can be, we know from other clinical educators in the NOI group that can be successful. That can be, people can be absolutely cured of CRPS, or at least their condition can be much better managed and quality of life improves significantly with that whole toolbox of approaches. There's no one tool that's the absolute right for these complex pain and fatigue states.
Yeah, I mean that's what I'm hearing very much is that that's the objective is to calm the system down in with all of these presentations that you're talking about and create safety. Would that be fair to
Absolutely.
say?
Absolutely, yeah, and psychologists on here, or if there are people with psychological training, the sort of soothe system. What do you do for self-care? These are all phrases and words that I think are crucial to help that broad spectrum of presentation. How do you get that system innately feeling more secure, more appropriately protected, more confident in its own vitality and its own resilience? This is
Mm,
how we begin to have a positive spin cycle that, with mood improving, pain reducing, sleep improving, fatigue improving, social life improving, return to work, return to
mm,
sport, all these things then become a positive spiral rather than, a commonly seen negative spiral.
mm. Does this tie back into your sort of your opening to this session where you said I'm going to try to just avoid to use the word pain?
Just that I'd like to talk about the other symptoms and the other presentations than
Mm,
just pain. But I think
mm,
you're absolutely, if the implication of that question, Joe, is sort of when we're talking with patients, pain is that thing that brings patients to our clinics,
yeah.
and we should pay due attention to pain. But there's that sense, and again, that sort of, it's really hard to articulate, isn't it? But that sense of that clinicians on this call will have of sitting across from someone or sitting with someone, knowing that there's more, and I think clinicians often have that worry about the phrase of opening the Pandora's box. If I ask this
Mm,
question, what do I find out? Am I equipped to deal with it? We have to be sensible about it, but we've also got to have that confidence that we do have. When
mm,
rightly phrased, have there been difficult things in life to cope with? Are those difficult things sort of ongoing? Can I ask, have there been difficult traumas in life that still resonate with you today? We don't need the details of those traumas, but
mm,
to understand why that person's is just sitting there a little bit prickly, a little bit spiky, and a little bit clearly with other things going on is a real
mm.
clinical skill.
Thank you. Fascinating. It would probably be. I'm just going to take a question, and this will be the last question that we ask live today. Madeline has asked about this seems to link in with the post-COVID syndrome, fatigue, mood, pain. Any thoughts or ideas on how to manage this from a physiotherapy point of view?
Um, the last bit, not massively. The first bit, absolutely. I think post-COVID, long COVID,
Mm,
is a disrupted immune system. It's that immune response. Perhaps your immune set point has moved up because of a prolonged COVID infection and the consequences of that, repeat COVID infections. And I think we are seeing, and we're trying to apply skills from the chronic fatigue world to post-COVID, perhaps from the chronic pain world to post-COVID, from the medical world of ensuring that this isn't, cardiopathy or other conditions that are now sort of manifesting post-COVID. It's a real tricky area to work in. But Madeline, absolutely, I think this is part of what we've been talking about. Is absolutely
mm,
that stress of not having clarity. You're coming to your primary care doctor, your GP, your COVID physician, respiratory physician with these symptoms, and there isn't a simple answer to this because
mm,
you've been ill for some time, you've had responses, you've maybe been off work for some time, mood has changed, sport has probably, and exercise has probably reduced, your fatigue is high. This is that post-COVID syndrome is a really good example of this multifaceted, multi-systemic impact.
yeah,
I think there's
yeah.
evidence for things like graded exercise and pacing and sleep hygiene and the right medications, antihistamine type medications for some.
Mm, thank you, Ben. Um, so I guess that what I'm really hearing here is that calming the system down using be that the physical system, emotional, cognitive system is the key, and it's not just a one-pronged attack here at all. You've
Absolutely.
got to be looking at all of the symptoms, and you've got to be looking at all of the systems. So, with that in mind for clinicians watching, what would be your sort of most practical takeaway from today, and how might somebody, we often do this at the end of a session to say, what's your key takeaway? What would be, or a couple of key takeaways from what we've talked about today, things to remember literally tomorrow morning when they go back into clinic?
Um, so what? Maybe there's two answers. One, this might come across as in somewhat slightly negative, but we will all know, clinicians on this call will all know that there's sometimes resistance to these inquisitivenesses about broader issues in life. The person's come to you with pain, you're asking about their mood state, they don't see the link and they get a bit defensive. I think we can absolutely kind of be respectful of that and say, look, that's absolutely fine. We don't need to kind of go there. Let's just think about whatever your professional input is. Let's just think about exercise. How much is exercise going to improve this? What are we targeting with exercise? You know, I estimate that we can probably improve this by 30%. If we only focus on the one prong, if we only take the one prong approach, we can probably make, these kind of changes. But there'll be some residual problems that we can't deal with that one prong. And that might be fine. And you might go with that. And that sort of, it almost sets the person up and you up to not expect that you're going to solve all their problems if you only take the one prong approach, the one single clinical direction of treatment. But I think to go to the second part of your question, what's the one thing I'd ask people to do tomorrow with that person who empathically there's more going on? Just ask really open questions. Have there been other difficult things? Have there been difficult things to cope with in life? Or something like, on a 0 to 10 scale, how would you rate your current stress? That could almost be enough to open up a conversation.
Brilliant. Thank you, Ben. Absolutely fantastic. So, we've just touched on this today, and Ben's given you a sort of very high level overview of some of the things that will be covered in a lot more depth, the skills, the tools that you need to implement this in your own clinical work. And so for those of you who might be interested in doing a deeper dive into these concepts, we're just going to talk a little bit about what you could expect from Ben's Explain Pain course, which is coming up on December the 4th and the 5th. And for those of you who have been inspired by what Ben has had to say today, can you just tell us a little bit more about the course and how what we've talked about today is covered in the course and what people might expect?
The course covers, what does EP cover, Joe? It covers patient assessment. What does this person in front of you need? What's their interest in Explain Pain? What's their interest in knowing something different? Is that person someone who's really open to new information, or are they quite closed off? If they're open to some new information, what kind of information? You've mentioned you opened up with target concepts. What are the likely top sort of messages we're wanting to get across? We then go into science around nociceptive pain, neuropathic pain, central mechanisms for pain, and a big sort of section on what we've been talking about, which is pain is not the only output. So these issues on sleep and threat and everything else that we've spent this last 20 minutes talking about. And then threaded through that, ways of educating, certain stories that often resonate, certain images and metaphors that resonate with people, certain resources to go to online, on the internet, print workbooks available by people out there on the internet that are really useful, podcasts, personal sort of phrases that you might use with people, and really how to use that whole range of education to emotionally hook people into the story you're talking. It's not just about knowledge transfer, it's about hooking in that person to understand and to then act on your clinical advice, whatever profession you're coming from. To sort of this foundation of then, why is this relevant? Why is this advice relevant to me and motivates me to kind of really act on it and put it into practice?
Fantastic. Thanks, Ben. So for anybody that is interested in attending Ben's course, the link is in the chat. Also, you can find the full course description and how to book on that on the Noi Group website. I believe we've got about 5 places left. So if you are interested, don't wait too long, because I know that the course is about 3/4 full. So thank you, Ben, for sharing your expertise with us today. Thank you even more so for managing to do it without being able to see yourself on screen.
That's all right. And
Um,
my apologies to everybody for, I don't know what's going on with this laptop today. It's all a bit of a rush to get this switched on, and
yeah, no
updates have
worries.
happened. So it could be that, yeah.
No
Thanks
worries at
everybody for
all.
joining though.
Yeah, the content's still there. Thanks, everybody. Thanks for your
Thanks,
time.
Joe.
Thanks for joining live. Thanks to everybody for your fantastic questions. As always, it's such an important part of what we do to connect with you guys, the people out there doing the work. So thanks so much, and keep your eyes open for the next one. Cheers. Have a good rest of your day, evening, wherever you are in the world. Thanks again.
Take care.
Bye for now. Bye.
Bye bye.
Take care.